Thank you for attending tonight's webinar that is hosted by our Physical and Mental Health and Social Action Committees. Thank you so much for bringing this opportunity to us, thanking my committees. My name is Ruth Price Rollins, and I am the president of the Greater Cleveland Alumni Chapter of Delta Sigma Theta Sorority Incorporated. I welcome you to tonight's webinar, hosted in collaboration with esteemed physicians and pro-choice leaders. We believe this to be a timely discussion focused on current issues impacting a woman's right to make reproductive decisions. In light of recent events, Delta Sigma Theta Sorority Incorporated has reaffirmed our stance that a woman has the right to choose. Our position can be found on our national website, and to lay the foundation of the program, I will state it now. Delta Sigma Theta Sorority Incorporated has been championing a woman's right to choose since 1973. Following the passage of Roe versus Wade through a codified resolution, and reiterated this belief in 2019 through the adoption of another resolution that reaffirms the sorority's belief in a woman's fundamental right to bodily autonomy. Matters pertaining to a woman's reproductive health do not belong in the hands of state legislatures or those with hidden agendas to politicize something so sacred. We must not stop fighting for the rights of all women, and hence all Americans, as we navigate the time between now and the final ruling by the Supreme Court. Members of Delta Sigma Theta Sorority Incorporated will continue to engage and educate state, local, and federal elected officials and members of the public on the importance of a woman's right to choose by advocating for legislation where necessary, participating in letter writing and mail campaigns, news releases, and other appropriate activities. Tonight's webinar helps us to spread the message about our position. I will now turn it over to our Social Action Committee to introduce the speakers. And again, welcome on behalf of our chapter, and thank you for being here.
All right, thank you, Madam President. Again, I am Meredith Turner. It's my honor and privilege to serve as the Social Action Committee Chair. Thank you all for joining in. I will co-moderate this evening's session. I have the pleasure of introducing our speakers for this evening. Dr. Joy Robinson Tidmore, a board-certified OBGYN, is a native of Birmingham, Alabama. She completed her undergraduate work at Florida A&M University, where she received a Bachelor's of Science degree in physical therapy. After 3 years of a rewarding career in physical therapy, Joy decided to pursue medicine. She later received her medical degree from the University of Alabama School of Medicine. From there, Joy finished her residency training in obstetrics and gynecology at the University of Pittsburgh's Medical Center, McGee Women's Hospital. Dr. Robinson Tidmore has practiced obstetrics, am I saying that right? Obstetrics and gynecology in the Cleveland area for over 20 years. She's currently with Cleveland Clinic, where she enjoys promoting women's health in general, with a special interest in fibroid management, minimally invasive gynecological surgery, and obesity medicine. Dr. Joy Robinson Tidmore.
Good evening. Thank you for that wonderful introduction.
You're welcome. Okay, next we have Kelly Copeland. She has served as the Executive Director of Pro-Choice Ohio since 2022. In her fight to protect reproductive freedom in Ohio, she has testified at over 50 legislative hearings and appeared in every major Ohio media outlet, the New York Times, Washington Post, USA Today, and many others. She helped create Patients to Advocates, a leadership development program for people who have had abortions. Alumni have gone on to serve as staff and board members at reproductive organizations, and she's testified at state and local hearings and became an abortion storyteller. She has a degree from the University of Akron. Her career includes working for the AFL-CIO and receiving numerous prestigious appointments. Kelly is a member of First Grace United Church of Christ in Akron. Kelly Copeland.
Thank you so much. It's an honor to be here with all of you tonight.
Linda D. Bradley, MD, is professor of OBGYN and reproductive biology at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. Dr. Bradley's clinical work includes director of the Center for Menstrual Disorders, Fibroids, and Hysteroscopic Services. Recently, she was appointed Vice Chair for Diversity and Inclusion for the Cleveland Clinic Women's Health Institute. She is an internationally recognized gynecological surgeon known for her expertise in diagnostic and operative hysteroscopy, saline infusion sonography, evaluation of abnormal uterine bleeding, and alternatives to hysterectomy. She was recently elected to the board as medical director for the American Association of Gynecologic Laparoscopy. Ooh, these words, laparoscopy.
Laparoscopy.
Yeah, she tell us how to say it. For the past 18 years, Linda has been a dedicated servant leader in Cleveland's multicultural community health and wellness programs. She is founder of Cleveland Clinic Celebrate Sisterhood and Cleveland Clinic Soul Steppers. Linda D. Bradley, MD. Finally, we have Becca Kendis, Esquire. She is a reproductive rights fellow at Case Western Reserve University School of Law, where she earned both her Juris Doctorate and Master of Social Science Administration. She earned her Bachelor of Arts in Social Change and Activism from the University of Michigan in 2012. Becca has passionately advocated on behalf of other vulnerable and marginalized populations at the ACLU of Ohio, Milestones Autism Resources, and NARL Pro-Choice Ohio. And she currently provides trauma-informed legal representation to victims of human trafficking and individuals at high risk of trafficking victimization. I now will welcome Dr. Kalia Fisher-Grace, our Physical and Mental Health Chair, to begin with questions for our distinguished panelists.
Thank you, Councilwoman Turner. We have a few questions for the presenters that will inform the audience on current state, and then we will take questions from those of you that are participating. Again, you can put questions in the chat at any time during tonight's event. I want to start with questions for Kelly and Becca. Kelly and Becca, I believe that the public reacted to the leaked opinion that Roe versus Wade would be overturned, but there are still some gaps that the broader audience needs to be filled in on. So let's talk about how we got here. Becca and Kelly, perhaps you can tell us who Thomas E. Dobbs is and what exactly is the Jackson Women's Health Organization? Then a few other questions. Then can you explain what's happening in the state of Mississippi and why the Mississippi State Department of Health and the Jackson Women's Organization are arguing in front of the Supreme Court? And then finally, can you help us understand how this is related to Roe versus Wade and Casey versus Planned Parenthood? So I know that's a lot of questions, and I will let you guys decide who can answer which first.
I think I'll defer to Becca since she is the resident legal expert among us. I'll let her start and I'll fill in where I can.
Definitely. Fill in anything I forget. I'm going to try to keep this as general and high level as possible because as an attorney, I tend to get into the details too much and we only have a limited amount of time here. But to start with, Jackson Women's Medical Organization is the plaintiff in this case. They are the only abortion clinic still open in Mississippi. And so they sued Dobbs, whose first name I'm sorry, I cannot remember at this moment, but he's basically the equivalent of the director of Mississippi's health department. They also sued some other government officials. The reason that they're suing these people specifically is because they have the power to enforce the law that's at issue here, the 15-week ban. So if I can back up really quickly, I can make this current lawsuit make a little more sense by just walking us through how we got here from Roe. So as I'm sure many of you know, Roe v. Wade is the landmark Supreme Court decision that found the right for a woman to choose to have an abortion within the United States Constitution and its protections of liberty. So despite finding that that was a fundamental right, it did not say that there could be no bans of abortions ever. It set certain parameters. So under Roe, states and the federal government could still ban abortion after the point that the third trimester started. And the reasoning there was at that time, given the medical knowledge and technology, that was considered to generally be where fetal viability occurred in the timing of a pregnancy. So after that, anti-abortion groups and states still continue trying to pass restrictions that made it more difficult to access abortion and passing barriers to getting abortion care. But so those restrictions were challenged, and eventually we made our way to a case called Planned Parenthood v. Casey in 1992, I believe. And in that case, the court had a chance to revisit Roe, and people were very concerned at that time that they were going to overturn Roe. That didn't happen at that point. They confirmed the central holding of Roe, which is that there is this fundamental right to choose to have an abortion. They did make some changes though. So the line at which point the government can now ban abortions was set at viability instead of the third trimester framework. So they set it at viability, which at that point I believe was considered to be around 23 to 24 weeks. I think that is still the time. The doctors will talk about that later, I'm sure, but I believe that's still generally the timing that we consider fetal viability to occur today. And so no bans after that point. So how we got here is that in 2018, Mississippi passed a ban at 15 weeks of pregnancy. So clearly this violated the line set by Roe and Casey. And the state knew this. This was a direct challenge to that framework. And so the abortion clinic, Jackson Women's Health Organization, they challenged this law immediately once this passed because they provided abortions, I believe, through 16 weeks. And this was blocking them from providing after 15 weeks. So they won, and both of the lower courts who said, this is clearly going against the understanding of the Constitution that was provided to us by the Supreme Court in 50 years worth of decisions. And so Mississippi was not done. They appealed again, and they asked the Supreme Court of the United States to look at this case. And unfortunately, the Supreme Court took it. That was already a hint to us that things weren't going great. But during those lower court cases, the issue that they were arguing mostly over was whether or not that viability line was the right line for bans. But as soon as they got in front of the Supreme Court of the United States, the arguments turned to whether or not the right to abortion under Roe and Casey should just be overturned entirely. So I'm sorry, that is my long-winded response of how we got here. Kelly, is there anything that I missed?
I think the only thing that I would add is that, you know, when they did get to the Supreme Court, it really boiled down to Roe says that each individual should be able to make that decision. They argued that the government should not be able to make that decision. And in that argument, they really erased the people who would most be impacted, you know, the pregnant people. And that really goes against the rule of law. And that's one of the reasons why it was so alarming. And the reason why we have a court that, you know, appears to be poised to overturn Roe is that it is now controlled by a majority of conservative justices after a string of appointments from former President Trump. You know, there was a real sea change over time over the ideological makeup of the justices on the Supreme Court. So there's a different ideological majority on the court now than there was when other cases were brought before the court.
Thank you, Becca and Kelly. I think that's very helpful. So the next question is for Dr. Robinson Sidmore, and it springs off of what Becca was beginning to mention as it relates to viability. So a lot of the oral arguments talk about what is viability, when does that occur? Can you explain to us what viability means and if there's a standard number of weeks that are associated with viability?
Sure. Yes. So to piggyback off a little bit of what Becca said, in general, viability is defined as the capacity of a fetus to have meaningful life outside the womb. And at the time of Roe, 1973, this was around the beginning of the third trimester, around 28 weeks gestation. So over the past 50 years, with medical advancement and medical improvement, particularly in the case of administering corticosteroids to fetuses up to that point, that number has now digressed down to where we are generally 23 to 24 weeks, considering that to be viable. The American College of Obstetrics and Gynecology has now also added a little gray zone to that definition with recommending administering corticosteroids to embryos and fetuses as young as 20 weeks, 1 day. And so that is a little bit of a gray zone, but the standard right now, I think across the board, is still 23 to 24 weeks.
Thank you. We appreciate that explanation. Dr. Bradley, we've heard what the argument is before the Supreme Court. We understand a little bit more about what viability means. But what often I think needs to be discussed, while this is focused on abortion, we want to expand the conversation. Can you just talk about what options exist for women that want to prevent pregnancy or find themselves in a situation where they need to terminate a pregnancy?
Can you hear me? Okay, good. Well, just to answer the first question first, I think it's important for women to know that pregnancy is possible from the time that a woman ovulates all the way until she is 1 full year after her last menstrual period, which is menopause. And women ovulate, release an egg before they actually have a period. So it's important to know that sexual activity, if it's once a day, 5 times a day, once a month, once a year, pregnancy is still possible when sexual activity occurs. What I want women to know is, I think your question is what's available. In 2022, we have so many more options than we did years ago. So we have pills, patches, potions, as I speak, vaginal rings, injectables, abstinence, permanent sterilization for women. We call it salpingectomy or tubal ligation. We have vasectomy. We have condoms. We have contraceptive sponges. There's a new contraceptive gel that can be given by prescription. So what I would say is that what I really want patients to know is that pregnancy happens without consistent use of birth control, and pregnancy can happen with birth control. And also I didn't mention condom use, diaphragm. So we just have a lot of options. And what I really want women to know is that there's so many myths, what we used to call old wives' tales about birth control safety and effectiveness. In 2022, I think sitting down with your healthcare provider to individualize, to have personalized care, to look at options that are available for you. I also did not mention all the modern intrauterine devices, from copper devices to hormonal devices, levonorgestrel, progesterone. There's a device, in fact, I was just at our national meeting. As Joy had mentioned about the American College of OBGYN, one of our devices, specifically the Mirena IUD, when it first came out, was good for 3 years. Then it went to 4, then at 5, then 6, and 7. And at the national meeting, the Mirena IUD is now being used to 8 to 10 years. Same device, invented in the late 90s, just shows with effective, that's strongly effective and very safe. And so I think there are just so many methods that please, for women, don't listen to what your girlfriend said, or your mother, or your grandmother. The IUD that's today was not the IUD from the 40s, 50s, and 60s. We as doctors do personalized care and individualize your risk. It is far riskier for some women to be pregnant, stay pregnant, than to use contraception. And also know that weight matters in some of the methods of contraception that we use in terms of its effectiveness. And as Ms. Grace had just mentioned, if someone finds themselves sexually active, did not use anything, condom broke, sadly for incest, rape, non-consensual intercourse, that there's also an over-the-counter pill that can be taken within 72 hours of unprotected sex. We call that Plan B. And there's another one that can be taken up to 5 days after unplanned sex. And that is a prescription item from a physician. So when I see many of my patients, even talking to women that are older, I ask, do you have a granddaughter, a niece, a family member that you take care of? I want women who aren't even menstruating, who are menopausal, to know that if they're everybody, it takes a village to raise a child. And many times the grandmother, auntie may have a better working relationship with the daughter, and that if she thinks that there's sexual activity or concern, know that there are preventive things. You don't always have to see a doctor. Nurse practitioners, midwives, Planned Parenthood, many types of practitioners. It doesn't have to be an MD, can see a woman and individualize her own risk. In general, for me, I personally wish that we had birth control pills that could be purchased over the counter, just like you buy aspirin and Tylenol and Motrin. I think that's the way to go, because it's a long way from getting a prescription from the doctor's office to the bedroom. And if we had that available for women and for men to know about women's bodies, to also equally be involved with the decision about sexuality when it is consensual, that everyone takes a part. And for women that, unfortunately, with rape and incest, where it's non-consensual, maybe that's a later part of the discussion. But what you need to do if you find yourself in a situation where there's harm been done, that you can prevent pregnancy by speaking up sooner, getting help, being evaluated for all the things that you can be exposed to, but also to prevent pregnancy. And let's just get rid of all of these myths about the lack of safety with modern low dose hormonal and even non-hormonal contraception. I think this is a great time to be sexually active and to make choices and to be responsible for sexual activity, and to prevent sexual activity if you forgot your pills, you're on an antibiotic. your condom broke, you just had sex. There's many things that can be done that are very effective and we should know about.
Thank you.
Mm-hmm.
Dr. Robinson Tidmore, we heard the explanation about the many, many options that are available to women, from contraception all the way up to what Dr. Bradley mentioned, Plan B, things like that. When we talk about Roe versus Wade and talk about the Dobbs versus Jackson Women's Health Organization, what are the things that concern you and your colleagues if this ruling were to be overturned as it relates to maybe unintended consequences or downstream effects for reproductive rights in general?
So let's start by just remembering that abortion as it stands today and should always stand is essential, comprehensive, evidence-based healthcare. Abortion is healthcare. And overturning Roe would put this into extreme jeopardy in terms of availability, equity, also in access to safe and abortion facilities and providers who are willing and wanting to provide the service, but accessibility to them. So as it stands right now, and Becca and Kelly, you may correct me if things are updated, but I think right now there are about 24 states who are poised to overturn Roe versus Wade or pass extreme legislation that would ban or significantly limit a woman's ability to have an abortion, no matter what the situation, whether it's maternal comorbidities or genetic disorders with the fetus, in addition to just unintended or unplanned pregnancy. So these things are always on the forefront of our minds as women, but healthcare providers, because that situation is going to come at our door. So the things that are that we discuss as providers are, what are the consequences for these women, for women who are seeking to find a safe, equitable place to have an abortion. So women who are in these situations or in these states where this may not be an option for them will either do one of three things. I think they will either find a state or travel to a state where they can have a safe and legal abortion. They will perhaps self-medicate or self-reduce the pregnancy or continue an unintended pregnancy. So those three things, neither of them are optimal, and all three things come with their own specific risk or limitations. For instance, there may be social or psychosocial factors that could prevent a woman from being able to travel to have a safe abortion. Actually, we're in Ohio. Ohio is probably going to be one of those states that could ban abortion or significantly limit it. So you would probably need to understand and know where your border states are. Right now, I think Pennsylvania is a border state here, and close by Massachusetts and Illinois. So those things are important for women to understand and have access to, but that could be a limiting factor in and of itself. Also, for women who elect to continue a pregnancy, this may be just an unintended pregnancy, but it also could be a pregnancy that may be marred by fetal abnormalities and or maternal comorbidities that could put the patient at significant risk if they continue the pregnancy. So now physicians and caregivers will need to be educated on how to manage these comorbidities that could possibly be life-threatening for both the fetus and or the mother. Thirdly, if a person tends to self-manage an abortion, now these are situations that could run the gamut between just an infection, uterine perforation, extreme sepsis, maternal death, ER doctors, family practitioners, people need to be aware and almost retrained on how to identify and manage these situations, because they will come up. The risk of this could be obviously the complications associated with reducing or self-managing an abortion, along with the possibility of maternal death. And these are real issues that will be trickled down or could trickle down if Roe is overturned. Those are the, I would say, immediate abortion issues that we think about as practitioners. But in addition to that, this judgment could begin a slippery slope to not only women's right to choose abortion, but also contraceptive rights, which right now we have the ability in most cases through our insurance carriers or just as individuals to purchase or acquire contraception, many options as Linda has mentioned. But these things could be in question as well if Roe is overturned. So I think this is a great time right now, today, to discuss with, as women, to discuss with your practitioners, your doctors, have discussions with your friends, your daughters, and your sons about the possibility of the consequences if this legislation does pass, because we our rights are in jeopardy at this point. And so I think these are conversations that we have as practitioners, but also we should have these among ourselves and plan to, at this point, in this juncture of our lives, really evaluate our reproductive history right now, or our future reproduction, and act accordingly. If unintended pregnancy is something that you would like to prevent in the near future, have those conversations with your physicians and figure out what's the best option for you. And also think long-term, because those things could be affected as well. So in general, to reiterate, abortion is healthcare. And I think every woman should have access to equitable, safe procedures, facilities, and physicians who want to provide this service for you.
And can I just add one quick thing here? Joy's explanation is just fabulous. You know, I like to look at history. And if I were to ask you to raise your hands or put your numbers out, how many pregnancies do you think women had a century ago? It's pretty amazing. 1800s, the average woman had 15 to 18 pregnancies. So 15 to 18. And so we now, as modern I'm not young, but modern women, spend more of our lives trying not to be pregnant than we are pregnant. So I just want to make sure we're looking at the scope. We're living longer. Back in the day, women didn't even live to menopause to have hot flashes and night sweats and diseases of aging, because they died in their 40s. And we can have, I delivered women at 51 without going through IVF. So we're sexual people. Pregnancy is possible throughout our whole lifespan. So I don't want to just say, oh, you're in your 20s, you know, you can get pregnant. Just as not as many women in their 40s, but pregnancy occurs across the whole spectrum. And you know, these unintended consequences have to do also with age. You know, 49 having a baby is very different than at 29 in terms of other comorbidities. And so I think abortion must be a part of the program, not program, but be a part of the healthcare choices for women. And we should enter pregnancy, a planned pregnancy, the healthiest that we can be, and to take all the precautions that we can. But when we find ourselves pregnant, know that there should be safe options, whether it's medical termination of pregnancy or surgical termination of pregnancy. So that's what I just wanted to add.
Thank you. I think we were going to ask you another question that you alluded to before we go back to Kelly and Becca. Just because we have so many, our sorority is predominantly African-American women. That's the majority of our audience today. Dr. Bradley, you and I talked at length about your concerns for African American women in terms of myth busting as it relates to abortion. So if you take your 1 minute and just give just what do you want Black women to know about abortion?
Abortions are safe. They're it should be performed by someone that is trained at a reputable facility, clinic, hospital. If that's for surgical abortions, if it's medical abortions, to know that you are given the right medications, the right doses, are being followed, to be able to have a phone number for 24/7 contact, availability to be with a provider. So what I want people to know is that if abortions are needed, it needs to be safe at a safe place, physician that's well-trained, not by someone in a back alley, but someone that's certified and with experience. And that's what I would say. And to also, as I mentioned earlier, for prevention of pregnancy, as much as possible, to always be faithful, compliant with whatever method of contraception that you choose, and choose a method that fits your lifestyle and also works well with any comorbidities that you have. So what I want Black women to know, the medications, contraception work for everybody, and just to have the critical conversation, and don't believe a lot of the things that you may read about on the internet. Talk with your healthcare provider.
Thank you. I turn it back over to Meredith.
Okay. We are going to be wrapping up soon and taking questions from the chat, but I have a few more questions. Becca, when can we expect to know the final ruling of the Supreme Court, and how can we be informed on updates related to the case?
Yeah, man, I wish I had a more definitive answer to that question, because it would make everyone's life a lot easier to at least know when to expect this. So generally, traditionally, the court releases their like blockbuster opinions in the big cases, the controversial cases, the last Monday of June. So if you take a look at like all those big cases you've read about in the last like 2 decades or so, that you'll see like June 27th, June 29th, things like that. That's what we were expecting, but the leak sort of threw a lot of things up in the air. And every time that there is a decision day on the schedule for the Supreme Court, like they schedule days where they announce their opinions. We were just holding our breath. So I personally still think that we might see it the last Monday of June, but it could also be a different day of the week. And they might even go into July, because they are so behind right now. They have so many decisions left that they haven't announced their opinions for. So by the beginning of July, that would be the definite like endpoint for when we'll know the answer. As for how you can stay informed, you can follow different organizations and their Twitter accounts, because I know all these organizations. I know Pro-Choice Ohio and Kelly are also watching the decisions as they come out every day. And I'm sure we'll be announcing that information over all their social media accounts. Or you can check the Supreme Court website itself. We'll note what days they're announcing opinions, and you can join us all in refreshing with our breath hold.
Thank you, Becca. Kelly, you have our final question of the evening before we open up for questions. Please explain what happens in Ohio if the Supreme Court overturns these cases.
Thank you. The first thing I want to say is to everyone here who's had an abortion, provided an abortion, helped someone get an abortion, fought to have abortion become legal, fought to keep it legal. I want you to know that we will never stop fighting for you and for this basic human right, no matter what happens. That's the first thing that will happen, is that we will not surrender to this tyranny. This will affect everyone. The impact will be felt most deeply by Black and Indigenous and people of color, by young people who may not realize they're pregnant, by LGBTQ people and non-binary people who have disproportionate access to healthcare issues, by people who live in rural communities in Appalachia because travel is so difficult. But this will impact everyone. The first thing in terms of Ohio, we're not one of those states where abortion will automatically be illegal, thanks to the work of advocates and just everyday Ohioans for the last 10 years to stave that off. We've had the full force of the state government and gerrymandered districts working against us for over a decade. And they've been trying to pass an all-out ban on abortion for all of that time. So abortion will not automatically become illegal like it would in Mississippi or it will in Kentucky. So that means that we may have actually initially a surge of patients like coming up from Kentucky and other places. But we do have a 6-week ban on abortion that was passed in 2019 that has been held up in the courts. We know that Governor DeWine and Attorney General Yost already have paperwork prepared to go to federal court and ask that the temporary restraining order on that law going into effect, they're going to ask that that be removed. That process will take several weeks because they'll file. Jesse Hill and Becca Kendis and other brilliant lawyers will have an opportunity to respond. We likely won't get the outcome we want there. It's possible that there will be further battles in state court. I'll speak to that a little bit more. So there's going to be this period of mass confusion. Patients are going to flood to Ohio. People are going to wonder, is abortion legal here? Because it's going to be illegal in a lot of places. So it's going to be really important, that question you asked, like, how do people know what's going on? When the 6-week ban, people thought abortion was illegal. And that right there can cause harm because people don't know where to go. They don't know what information is accurate. Anti-abortion organizations are going to flood social media with misinformation. So, making sure that people know when abortion is legal, that there are still 9 clinics in Ohio, including preterm and Planned Parenthood here in the Cleveland area, that's going to be super important. We could very soon after the decision, maybe a month, maybe a little bit longer, be in a situation very similar to Texas, where we would be under what is essentially a 6-week ban. So it will be really important for people who need abortion access to identify that they're pregnant and be able to get to a clinic if they don't want to continue that pregnancy as quickly as possible. People who are not able to do that, there are groups, abortion funds, and others like Women Have Options Ohio and others will be working on what we call practical support, patient navigation, to get people out of Ohio to states where abortion will remain legal and available. Currently, we believe that will include Michigan and Pennsylvania, but those states also have elections this year. If those states should fall, the next closest places will be New York, Illinois, Maryland, and Virginia. The cost for travel to those places could be, with gas prices, $400. We're talking about hundreds of miles to get there. So supporting Ohio's abortion funds so that people can get to those places will be important. Also, people will be looking to get medication abortion medications online to self-manage their abortions. We know that Republicans in Ohio who control the legislature, anti-choice people, they intend to pass a total ban on abortion. The timing of that, we don't know. They're not scheduled to be in session until after the election in November, but they could come back anytime they like. The current ban that we've been fighting includes no exceptions, not even to save the life of the patient. And depending on how they write that, a ban that would ban any kind of abortion or the way that they might write it. It could even interfere with some forms of contraception. We have seen them write legislation that's at that extreme. So, you know, we could be talking about Plan B, IUDs, other things like that. Certainly, it's troubling what could happen to, you know, the ability of like people like Dr. Bradley and Dr. Robinson Tidmore to help people who are having ectopic pregnancies or other pregnancy complications, people who are going through IVF treatments and other fertility issues, miscarriage management, all of that is of serious concern. We will work, so there's going to be these 3 phases: keeping abortion legal for as many people as possible for as long as possible, obviously harm reduction, and then working to reestablish and expand access to legal abortion. That's going to involve culture change, you know, making more support for abortion access, the practical support we talked about, blocking the criminalization of people for pregnancy outcomes. We're deeply concerned about that, particularly for populations that are already over-criminalized. There will be battles in court. You know, Becca and others will be battling in state court. That means that whoever controls the state Supreme Court in Ohio, which is elected, unlike the US Supreme Court, they could ultimately be who decides whether or not abortion remains legal in Ohio in the next weeks, months, and years. Ultimately, I think it's likely we will have to fight this on the ballot and amend the Constitution of the state of Ohio. So I think, and we're lucky in Ohio in that we have those options. We're not as lucky as a place like New York that's already codified these rights, but we're more lucky than a place like Texas or North Carolina does not have these options ahead of them. So in Ohio, there are paths forward. There are rocky roads, they are uphill battles, but they are paths that others do not have available to them. And I think that there's just so many ways for people to get involved. And my hope is that the number one thing that will happen after this ruling is that we will come together as a community to take care of each other, to make sure that everyone who needs care gets that care safely, and that we will fight to reestablish access to abortion, because Roe was never enough. We should establish access to abortion that is real access for everyone, which we have not had, not even since Roe. And so that's what I hope will happen.
Thank you, Kelly. We do have a number of questions in the chat that we're going to begin to answer. So thank you to the audience. The first question I'll ask Dr. Robinson Tidmore, you may have been the one that mentioned this. There's a question asking, what is the difference between a medical and surgical abortion?
So the basic difference is a medical abortion is treated medically with medications that are prescribed, and a surgical abortion requires a surgical procedure. But technically, a medical abortion can be done up to 70 days or 10 weeks gestation that's confirmed by ultrasound. And this is where the patient will, see a provider, establish, correct gestational age, proper counseling, and in a safe medical environment with skilled doctors and nurses be given a couple of medications to in the pregnancy. One medication will be used to actually cause the developing embryo to stop growing, and the second medication will be given to used to cause uterine contraction or evacuation of the uterus. The second type of abortion is surgical. And in Ohio, we can do surgical abortions up to 20 weeks, 6 days. And for up to 13 weeks, this can be done by what we call as a vacuum extraction. So this is just a suction extraction to evacuate the uterus. After 13 weeks, that would involve a few different additional procedures. One would be dilating the uterus, or dilating the cervix, which would be done a little bit ahead of time, followed by what we call a D&E, or the dilation and then evacuation of the uterus using other surgical instruments and techniques. But yes, those are the two general basic forms of abortion, and both requiring safe facilities and skilled physicians.
Okay, I was trying to come off mute. We'll take our next question. Are abortions usually covered by insurance since they are considered a form of contraception, or do most people have to pay out of the pocket? And also, is the biological clock myth true? And why is Plan B so expensive? Dr. Bradley, and if you also want to sound in, Dr. Joy, you may.
You know, the price of medications, I obviously neither she or I can talk about that. It's just like how do medications get certain names. I don't know.
Mm-hmm.
So I'm not sure I can answer that. I don't know. We often, I don't know, Joy, if you know the answer to this. There's something called Good RX,
Mm-hmm.
which is you can just go to a website, and this goes for any medication for friends, family, yourself, where certain medications are a tremendous discount. It's a good question. I have never gone there to look for that particular, like a plan, actually would be called Ella. Ella is a prescription that would be the one that you could use up to 5 days after unprotected intercourse. So I don't know why I don't know that answer to that question. Joy, do you want to have an idea of why these are expensive?
No, I really can't, again, speak to that. A lot of this is, big pharma controlled. So out of the scope of what I can understand or do anything about. But again, GoodRx is a method of being able to reduce the cost of some of these medications. Honestly, I don't know if Ella would fall into those categories. I've just never tried it, and I'm not sure if I don't think I've had a patient who's at least have mentioned it to me at this point. But it would be a great place to start. And because as of now, there's no generic for Ella, so it would have to be prescription brand name. So that's a cost that I don't think is going to change significantly at this point.
Right, but it is covered many different. There's over 65 birth control pills, and you can often get that from GoodRx.
Right.
The second question I think had to do with insurance. Another good question. I'm not 100% sure about that answer, to be quite honest, because most of the patients that I know are paying out of pocket. Right. So again, I'm going to ask my colleague Joy if she's had any experience. I don't see that as something that's being billed unless it is associated with a fetal anomaly later on during the gestation.
Right, and typically in those situations, I'm not the person that's seeing that patient, so I don't know if those are covered based on those particular diagnoses. So I don't have an answer for that at all either.
Becca, you were going to comment?
Sorry. Can I speak to that really quickly?
Yes, go ahead.
Okay, so whether or not abortion is covered largely has to do with whether or not you have private abortion, or I'm sorry, whether or not you have private insurance or public insurance. So there's a law called the Hyde Amendment, which maybe some of you have heard of in the news, that was passed a long time ago, and it prohibits federal funds from being used to pay for abortions if a person has Medicare or Medicaid. Ohio also has a law that prevents Ohio's Medicare or Medicaid funds from being used to cover abortion. And both of these have exceptions in the case of a risk to the life of the pregnant person, or if the pregnancy was the result of rape or incest. Now, private insurance companies, they are not mandated to cover abortion as well. So it really is up to these private companies to decide. Many private insurance companies in Ohio do cover abortion, but again, so this is another reason why there is such inequity in terms of abortion access between communities, because of the denial of coverage to people who are covered by Medicare and Medicaid. It's just another way that we see these disparities.
Becca, thank you. I think this next question in the chat might be for best answered by you. It's just stating that there are points made about access to contraception, and will Roe versus Wade being possibly overturned bring Griswold versus Connecticut into question, with the two being closely related?
Yeah, so we are very concerned about that. We don't know how similar the final opinion is going to look to the draft opinion that we saw being circulated. There was some language in there that I know some people want to sort of hang on, that said that the ruling was specific to abortion and shouldn't be assumed to apply everywhere else. But that really is meaningless language, because what they are doing is they are, with that opinion and assuming that it's going to look at least pretty similar in the end, they are saying that there is no right to privacy, which is an unenumerated right. So we can assume that in 1852, when this version of the Ohio Constitution was written, or that in the 1700s, when the federal Constitution was written, that all of these people knew how that they knew of everything that might come up in the future, right? So they use broad words. They use words like liberty and, justice, and things that we assume are applied, even if the specific words abortion were included. They can't, because they knew that they couldn't include every word. But there is a group of legal scholars, and many of those include the Supreme Court justices, that believe that the fact that it wasn't stated in there means that there is no right. So that right to privacy under our protection of liberty in the federal Constitution, that was the basis of finding that people had a right to contraception, married or unmarried. And so when we're saying that right to privacy doesn't exist in the case of abortion, yes, we are completely undermining that entire line of cases. Also, which led to the decision saying that gay marriage should be legal, and lots of other decisions regarding our private choices about our reproductive lives and our families. So yeah, it's definitely a concern. I hate to be the bearer of bad news.
Okay, Kelly, maybe you can answer this question. What happens if a woman travels to another state to have an abortion? Or Becca, you can jump in as well. If her state bans it, and how would that affect insurance coverage? Could there be legal action taken against her if her insurance picks it up?
Yeah, I mean, I'm going to defer to Becca on some of the legal aspects. In terms of insurance coverage, it depends, as you heard earlier, on your insurance. If your insurance covers abortion, if you have private insurance that does that, it may not matter in terms of the coverage, but there is a lot of concern about particularly these kind of, the SB 5 that was passed in Texas is not a criminal ban on abortion, but it provided a mechanism for people to go to court and sue, saying that someone had had an abortion, and claim a $10,000 bounty. So it was a way for them to get around the state being the one that could be challenged by their version of the 6-week ban. And one of the concerns that we have is, what will happen to information if things like that are passed in other states? Because some companies have come out, like Amazon and others, and said, hey, we'll help our employees access abortion care. Will help them, with those costs if they have to go to other states. And I think there are concerns about what might happen with that information, or could information be obtained from like your cell phone carrier for your tracking on your phone, or from your internet provider, from the IP addresses that you're at and the websites that you use. There are a myriad of concerns about private information and how that might be used to criminalize or otherwise put people at jeopardy.
Thank you. Becca, I don't know if you wanted to add anything.
I will just say that this is a conversation that I've been having every single day for the last couple of weeks with organizations and attorneys across the country. We know that certain states are not content at stopping with banning abortion in their state. Some states are trying to pass laws that would allow them to prohibit people from getting an abortion in another state, or that would criminalize people who assist someone else to get to another state. So providing somebody the funds to get that bus ticket, giving somebody a ride to the other state. We don't think that these should be legal, and we are preparing to deal with this through different legal strategies. But there's going to be a ton of confusion about this. If anybody has specific questions about whether there will be consequences, I think in Ohio, where just as long as you're going to a state where it is legal and you're completing your entire abortion there, at day one, that should be fine. But again, the landscape is going to be changing rapidly. There are legal hotlines for individual questions about like the legality of your abortion and what are options for you that you can access. And I will send some links to Meredith after this event tonight so that people have access to that. And also, we field questions like this all the time too. So I would say there are resources, and if you are nervous, ask, but there should always be a way for you to be able to obtain an abortion if it's in another state where it's legal.
Thank you. I'm gonna skip over a few questions that I think are maybe more directed for Becca and Kelly, just to get to some of the questions that might be best answered by the physicians. And I'll try to take to one. Dr. Bradley, you discussed Ella. There's a question about what are accessible alternatives to Plan B and Ella for women who have a higher BMI? And then I don't know if Dr. Robinson Tidmore, you might be able to answer what could a woman expect if they show up at a preterm, I'm assuming at an abortion clinic in terms of treatment and counseling. So Dr. Bradley, I'll ask you first to respond about Ella and Plan B for higher BMI.
Let me just really quickly just talk about birth control pills, which has been around since 1960s. When you look at clinical trials, meaning when a drug is tested, no matter what the drug is, their inclusion and exclusion criteria to be a part of a study. So for the birth control pills, many of the trials excluded women with who were over a certain BMI or weight. So there's a part of what we know as physicians looking at medicines that were never tested among certain types of patients in terms of weight. What we found out with the drug, it was the Ortho-Evra skin patch that came out years ago when they looked at the women who got pregnant with the skin patch. They were usually over 188 to 198 pounds. And that is what led to people saying, well, maybe women, the metabolism is different, because in clinical trials, women were not, you couldn't be 200 pounds and be in a trial to be studied about effectiveness. So I usually counsel my patients, knowing that little bit of data, recommend that women really strongly can use IUD. To me, it's the easiest, it's safe, it's effective. And also always do, if you're over ideal body weight to always have a backup with condoms. So I do talk to my patients about that and try to look at something that's more protective. It's a slight, taking the pill is better than no pill. But if you had a choice to go with the most highly successful way to prevent pregnancy, if you didn't want to take a pill every day, it would be insertion of an intrauterine device. And then secondly, just in clinical trials looking at effectiveness for Plan B, which is a pill you can take, you know, within 72 hours of unprotected intercourse. Again, Ella, which is an anti-progesterone medication, seem to have fewer pregnancies. That can be used up to 5 days after unprotected intercourse. So I would recommend that women have over ideal body weight, get a prescription from their physician if they want to get the highest level of pregnancy prevention with a morning after contraception. That's kind of how I look at it. I'm not sure if I answered the question. And one last quick thing, I think the era of COVID also has given us a great opportunity to do virtual visits. You don't have to come into your physician's office. There's a lot of myths. You don't need a pap test before you have or put on birth control pills. You don't have to have a bimanual and internal exam. So if you're in need for something, check with physicians' offices because you do require a prescription here in the US, but you don't really need to be seen. And again, there's an art to medicine and a science to medicine. Some doctors are still practicing light years away, but more progressive physicians are comfortable prescribing medication to patients over the phone without being seen in the office with no other major comorbidities.
Thank you. Then Dr. Robinson said more.
Yes, I think in addition to that, or to piggyback off of that, I think when a woman makes the decision to proceed with an abortion, whether it's medical or surgical, a lot in the advent of COVID, a lot of these intake and counseling situations are done prior to the patient actually coming to the facility. So within that visit, typically it will involve, in general, a physical examination and an ultrasound to confirm dating. There's clinical and psychological and psychiatric support there. There's counseling. And then there's a time where the consent is reviewed. The consent is reviewed and signed, and the procedure or medications prescribed or procedure is scheduled. Also in that visit, a woman would understand the risk of either procedure and have follow-up appointments scheduled. The other concern or other important step in this process that's usually addressed during that visit is contraception after the abortion. So that's a time where the doctor can sit down, or the provider can sit down with the patient and discuss alternatives and what's best for the patient based on their comorbidities or their future fertility issues and things like that. So the visit in itself is pretty comprehensive in general. The facilities that are here in Cleveland are staffed by doctors who are dedicated to providing this service for women and will support you. You will not typically feel like you're going there and being stigmatized in any way. And that's from the nursing staff to the phlebotomists who are drawing your blood, ultrasonographers, the physicians, the people giving you your anesthesia. It is a place where you can feel safe, emotionally supported, and safe in the procedure. So that's the overview of what to expect typically when you would consider an abortion and find a facility.
You know, she rings a great point. I'm at we're both at the clinic, but we, when you look at young doctors that are starting in July 1st of this year, we're both OBGYNs. We can decide, do I want to be a cancer doctor? Do I want to take care of high-risk women? Do I want to help women who can't seem to get pregnant the usual way, infertility doctor? Do I want to do that? Do I want to become a urogynecologist, a doctor who handles leaky bladders, women who urinate on themselves, cough and sneeze and urinate, lose their stool. So we get to choose as an OB what we want to do. There is a new field. We just are graduating 2 doctors who are graduating to provide their area of interest is abortion care. So what Dr. Titmore is saying, if you go to one of these centers, these are not back alley doctors. These are doctors who are spending 4 years. They are dedicated to the care of women, the safest way. Maybe there's new medications down the line. I mean, back in the day when I was a resident, some of the doctors that were doing abortion had lost their licenses, had never really finished all their training. It was, yes, you're a doctor, but there are a lot of red flags that made you a little afraid to go or refer patients to certain centers. So I must say in 2022, and she and I are involved with ACOG, and to know that young doctors are very interested, just like I'm interested in knowing everything, how to keep women from having a hysterectomy. That's my passion. And I study that. There are doctors who are going to training, and we as hospitals allow that kind of, instead of, they're never going to do cancer surgery. So they want to spend their surgical time getting all the experience doing abortions and taking care, high risk contraception. We have doctors that you could see if you were at the quote, you think you have so high risk, I can't take anything. No, we can find something that you can take. So Planned Parenthood and services like that, some hospitals employ physicians, and these young doctors, men and women, are very dedicated to the preserving safe, effective pregnancy terminations. And I also want to say, please get rid of the myths that abortions cause breast cancer, that you're going to be depressed and anxious, you're going to die early, you're going to have poor pregnancy outcomes. All untrue. Untrue. So please be careful about what you're reading. Safe abortions are safe, just like having your appendix out, okay, your tonsils out. Need to be done properly and handled if there are any issues with a team of physicians, nurses that know what to do if there are any sequelae. But I think there's a lot of fear factors and fear mongering. But on the science part of it, all untrue, all untrue.
Thank you, Dr. Bradley. This could be for either Becca or Kelly or both. In Florida, a synagogue is currently suing the state due to the passage of a law prohibiting abortions past 15 weeks. And since it violates their religious rights, what could be the potential domino effect for other rights, for example, religious rights, et cetera, after this ruling?
Okay, if I take this, Kelly? Awesome. Okay, so I see there's a couple questions about the impact that this ruling could have on various rights, including freedom of religion and voting rights. As I mentioned earlier, the primary constitutional rights that we are concerned about being eroded by this decision are those that fall under the implied right to privacy. So LGBT rights. Some people are even concerned about things like interracial marriage, or at least decisions that have resulted from that seminal case. That we are not concerned about at this point, about the Supreme Court overly eroding religious freedom. They are very into that, I will say. Yes, we do believe that these bans do erode religious freedom. And what you're seeing in Florida is a new response. So typically these legal challenges to laws have been based on the right to abortion. But since that's not going to be available to us anymore, we can't rely on that anymore. Attorneys and clinics, we are all working together to find other ways to challenge these laws with the knowledge that they challenge lots of rights. And if we can't rely on the federal right to abortion, we can still challenge some of these laws on things like violating our freedom to religious practice. We can challenge them on things like violation of due process if they're too vague, we can look to our state constitutions, which provide independent and sometimes broader protections for individual rights and liberties, and challenge them in those ways. So in Ohio, we have several cases currently going where we have filed them under law or under theories that are unrelated to the federal right to abortion, and it was because we were anticipating an outcome like this. So I don't want people to completely give up hope on that. We've got a lot of tricks up our sleeves still, and I would look at things like the Florida lawsuit as a hopeful thing, that to see the way that we are adjusting to still fight back, legally at least.
Thank you. I know that we're hoping to wrap up soon, so I'm going to try to take 3 questions and wrap them into one from Danielle, Ariel, and Essence. I think what these questions are bringing to light are those that are most vulnerable. So Black women, those who have mental health issues or concerns. What do we think about when we think about women who are vulnerable, who may have a right taken away from them to make a choice about abortion, reproduction, any of those things? How, and maybe you know how this is even being looked at in the current case. So anything you want to add to that question about what do we do for the most vulnerable? I don't know if Kelly, you want to speak to that.
Yeah, I think one of the most important things is going to be supporting organizations that provide material support to people who need access. Organizations that are helping people access care, helping them with travel and those things, because we know that when people are forced to continue pregnancies against their will, you know, and I'm sure Dr. Bradley and Dr. Robinson Tidmore can talk about more in a much better fashion than I ever could, the health impacts that are disproportionate to Black women and Black families, you know, the appallingly high infant and maternal mortality rates. You know, if more people are continuing pregnancies against their will, that, you know, undoubtedly puts more people at risk. But also, you know, we know when people can't access care, you know, that can be the thing that forces their family into poverty or to stay in poverty longer. It can eliminate people's access to the education they were pursuing, job opportunities. 60% of the people who have abortions are single parents. You know, this impacts the entire family, and often as a single parent, they are the primary breadwinner for the family. And so, you know, having a pregnancy, you know, there are not, in most cases, paid family leave. Ohio doesn't even guarantee a minimum unpaid maternity leave. There's no minimum unpaid maternity leave in Ohio. So, you know, a pregnancy could result in job loss. You know, most employers, I mean, they're not required to even provide pregnancy accommodations. People who work in nursing homes, other places like that, they're not required. You know, if you work in a retail environment, anything like that where you have to be on your feet, where you're doing physical work, they're not required to provide any sort of workplace accommodations. So the impact that people are going to have, I mean, it's just hard to overstate. And so making sure that people, if they decide that an abortion, you know, if they've, you know, gotten pregnant when they didn't want to, or they've had a complication and they've decided that ending that pregnancy is what they need to do, you know, we have to move heaven and earth to make sure that they can safely do that. You know, whether that's, you know, getting them to care out of state or helping them find ways to safely manage their abortions on their own, whatever that looks like. I mean, that's just imperative. And so, you know, there are groups like Women Have Options in Ohio. I'm sorry, my emotional support cat showed up because I just get so upset about these things. You know, the Midwest access groups. I mean, there's the Aggie Fund in Toledo, Preterm and Planned Parenthood. You know, all of them will be working on on these things. And I just think that's probably the most important thing that we can do. There are groups who have been working on this for a long time. I don't know that we need to reinvent the wheel. They've already looked into all of the legal aspects, the liability, how we help people with transportation, how they vet volunteers, how they, center the patient on all of those things. And I just think that's the best thing that we can do.
Yes, I also think that in general, the advocacy of education is invaluable. So at every level, when a woman is in front of someone who can give her information about either preventing pregnancy or safe, equitable ways to achieve an abortion, that should be standard of care, not something that is mentioned as a side note or as your hands on the door walking out of the room with the patient. So, if I could have that conversation in every doctor's office, as long as the woman is, as Linda mentioned, from ovulation to menopause and a year beyond, that would be a huge step in giving women the opportunity to make decisions proactively to prevent pregnancy and actually address their future fertility and prevent pregnancy and terminate pregnancy if that's an option for them. I think so often we are, and importantly, focused on sexual health, which is important, and reproductive health in terms of pregnancy prevention in our schools, that we don't talk about options for safety when it comes to having a place for girls and young women to go if this is an option for them, as this is a decision they've made. Again, the stigmas are real. Linda, I'm sure you see this all the time. The woman, no matter what the age or situation, comes in just not sure of their options. And spending time and talking to women about these things is time that that's really invaluable to them. They have resources out there that they can tap into and break the stigmatism of this being something that is so taboo. And sometimes just cracking that egg and breaking through that shell is enough to get a woman out there motivated to control their own health. So I think education and advocacy for your patients and education throughout the reproductive history of a woman is important.
And I think, while I know we're going to be closing soon, I have to always think of anecdotes and stories. We will speak with our patients, and maybe it's the way I ask the question, but I'll ask women, however the conversation goes, do you want to be a mother this year or next year? Do you want to be pregnant, or do you want to be a mother? Those kinds of questions. And then you ask about sexual activity, and I'll say, well, are you sexually active? I think I have to be better at this. And then they'll say no. But then you ask another question, and you'll say, well, how often are you having intercourse? I'm having sex 3 times a week. So I put my head and said, well, you just told me, I just asked you if you're sexually active. Then I wonder if the patients are thinking, like, are you sexually active, like right now while you're talking to me? So it's I have to get better. I am getting better with this, but I think it's real important for women to, if we are sexually active, do you want to be a mother? Do you want to be pregnant? What can you do? And let's just get rid of the myths. I mean, the reality is most people on this earth are unplanned, okay? Especially of a certain generation. 85% of us, our parents didn't plan for us that day, that month, that year, okay? And if you're under 35, think of the lottery, okay? If you're under 35, 85 times out of 100, within 1 year of not using birth control, you will be pregnant. And I flip it and tell my patients, if there was a $3 trillion lottery ticket and I had an 85% chance of winning, I play it, right? So having sex when you're younger, it's not just once a month. It could be, all it takes is one time. So I think there's such a myth between I'm not having sex every day. It doesn't have to be that. And the same thing at the other end of life. 4% of abortions are done in women in their 40s. And so I think if you don't want to be a mother, let's just take precaution. It also brings up the issue for being evaluated for sexually transmitted diseases. I have to put in there, we need to get our pap test, our mammograms. Those are some other things that I just have to bring in with this discussion because we are a captive audience. And we need, as doctors, to screen the unscreened. We need to, just like we get COVID testing, have our young women and young boys to get the HPV testing. Put Joy and I out of business for things like making a diagnosis of cervical cancer, needing to do colposcopy. There's a lot to women's health care. Sex is important, but there's such a dichotomy where so many things we could be put out of business for, and wellness matters. Each day we get a chance to choose health, self-care, self-compassion, and are taking really being thoughtful about our sexuality across our entire reproductive life, our seasons, is so important. And what better time? I wish I were a teenager now and not have to try to find out information. Go to good sources, go to good references. Don't look at everything that's on that internet or whatever. And as Maya Angelou says, how does it go? When you know better, you do better. And so we know better ways to get contraception, how to keep from pregnancy. And if you know somebody that's being harmed and has been sexually assaulted, get them to a physician all the time. I don't know about you, Joy, but I used to do hundreds of rape cases. That was a part of our training, just like coming in for a delivery. Don't wait if you're assaulted. There are things that we can do, like the Ella or Plan B, to prevent pregnancy. Don't be ashamed. Happens to many, many women, and you're not alone. And our healthcare providers, we are all teachers. The word doctor means teacher. We are training young physicians and our nurses to be allies, to be advocates for women. Find the right provider, and not every provider is for you. Yes. Okay, you have to find what fits, go by your intuition, and we know our bodies, we know ourselves, and take care of ourselves. That's what I would say. And look at, we are more than the sum of our body parts. Think holistically about your whole self. Are you in the right relationships? Is the person, if it's heterosexual, using condoms? I used to say no glove, no love, and I'll end it at that.
All right, thank you, Dr. Bradley. We love your passion. Becca, I'm gonna give you the final word.
Okay, wow. So I guess all that I would want to say is that there are so many states with so much less hope than us. I know that this conversation can be very depressing, but if we all come together and work from the levels of supporting people get practical access by funding and by volunteering, and just by helping our friends and family, if we work on voting the right people in, if we advocate for against and for policies at the state level, and if we just continue to not take our eyes off of what is happening, despite all the other things happening in the world, we here in Ohio have a real chance to at least maintain some access that so many people are not lucky enough to have in other states. And I want to encourage everybody to please take a look at the very, very pivotal Ohio Supreme Court elections happening this fall. I can't say much more about that, but please, this is going to be hugely determinative in the rights in Ohio going forward. And then I will turn it back. Thank you so much for having all of us. I'm particularly honored to be included here. And if you have any questions, you can feel free to reach out to me on email.
Absolutely. Thank you. Thank you so much. Just want to take this time to thank Social Action's partner, the Physical and Mental Health Committee, Crystal and Kalia, it's always amazing to work with you ladies. I wanted to thank both our technology and publicity committees for your support. Our president, Ruth Price Rollins. I think I saw our first vice president on, Melanie Frazier. And to our audience, thank you for always supporting us. And I'm going to turn it back over to Dr. Kalia to close us out.
Thank you, Meredith. And again, to our esteemed panelists, we are very fortunate to have had you here and to really answer a lot of questions, share your knowledge. We look forward to continuing the discussion as the ruling goes forward. And in the meantime, as Becca stated, and Kelly, paying attention to the pivotal races, prochoice.org or prochoiceohio.org, but also what Doctors Robinson, Tidmore, and Bradley stated, talk to your physician, your provider, be it a physician, nurse practitioner. If you have any questions, they've given you a ton of resources and options. So those are the takeaways. We thank you, and we are ending and saying good night. Stay cool.
Good night. Thank you.
Thank you. Bye-bye.
Thank you.